status, they find that those who live alone, those who are divorced, those who are single, widowed, are more likely to suffer from dementia than those who are still married and living with someone else. Okay? And the other thing is the educational level. As you see different colors, you may not be able to read, but those who have no formal education, the red bar, are more likely to suffer from dementia.
So the mic is not working now. I'm not sure if it's a sign. Okay, sorry. Mic not working. Yeah, but I can talk very loud, so it's okay. Cannot hear. Maybe I press.
Okay, I shall not move my hand too much then. Okay, so what are the risk factors of getting dementia? You don't have to think about reading the words there because you won't be able to. But people have looked at what are the causes of dementia and why do some people get dementia. I can tell you 60% of the cause of dementia we don't know. And likely possibly genetic makeup. But at least 40% of the risk factors we do know. So I'm going to tell you what are those 40%. So dementia is not just for older person to know about. It is something that you may accumulate the risk factors throughout your life course, from when you are very young to midlife to later life. So this is telling you that there is always something that you can do, no matter what age you are now, to reduce the risk. Okay? So I'm just going to show you it in a slightly larger font. So in early life, they found that people who have attained more than at least 12 years of education in their younger life are less likely to develop dementia. So the more formal education you have received, the less likely your chances of getting dementia. This is something we call it the brain reserve. So you accumulate more brain reserve during your early to your midlife, so that in case if you do develop the disease, you are not going to present with the symptoms so early because you have bigger and larger brain reserve. Like if you exercise, you build up stronger muscles, right? So you're more likely to withstand illnesses and sickness than if you have no muscle and you are weak. So similar with your brain. The more you use your brain, even after you retire, you have to think about doing something, not just stay at home, shake leg. So you continue to do something to challenge your brain, you build up bigger brain reserve so that your risk of getting dementia will be lower. Okay? So as you come towards your midlife, there are other things that you have to think about. So number one, people who suffer from hearing problem. So if you have hearing loss or if you have hearing impairment, go and check it out. Because we find that those people who persistently have hearing problem has a slightly higher risk. Okay, am I getting people worried now? No, still going on. Those who have history of traumatic brain injury, whether it's a motor vehicle accident or falling injuries and things like that. Other ones are like untreated hypertension, excessive alcohol, and also obesity. So these are the risk factors in midlife that increases your risk of developing dementia. Okay? So it's not rocket science. So basically the aim is to maintain people as healthy as possible for as long as possible. Okay? And even as they come to later life, there are still things that you can change to reduce your risk. So for example, we find that one big one that was quite interesting to know is social isolation. Older people who live alone, who doesn't come out to the community, who has very small circle of social life, has higher risk. So that's why we want to engage older person to maintain them as active as we can rather than being isolated because the risk is higher. Older person who has untreated mental health problems such as depression also increase the risk. So depression and dementia is quite closely related. Okay, even in midlife, if anyone has untreated depression, the risk of developing dementia is higher. Okay, and other ones are like diabetes, smoking, and this air pollution one is also something that the researchers have found. We're talking about air pollution like car fumes, those people who live in more congested area, very small. Okay, otherwise we'll all be very worried. These are the risk factors. So it's just telling us that there is always something that we can change throughout our life course. Okay. Now, some people always ask me, so what's the difference between dementia and Alzheimer's disease? So this picture gives you a broad idea. So dementia is like an umbrella term. As mentioned, dementia means your brain has failed, okay, to perform its function. And there are many reasons why this happened. So Alzheimer's disease is just one of the commonest cause of dementia. You have other causes of dementia, such as what we call vascular disease, Lewy body dementia, and also frontal temporal dementia. Of course, there are also many other rare subtypes which I have not put in here, but these are the common ones that we do see. Commonest, Alzheimer's disease. Vascular disease is when there is a lot of blockages in the brain. People who've had history of stroke, then they are more at risk of vascular dementia. So how they present might differ a little bit in their initial presentation. Alzheimer's disease is what we call a memory problem. So the older person usually presents with forgetfulness, cannot remember things. Okay? Whereas vascular, it might be a difficulty in initiating tasks, difficulties doing things that they used to be able to do before, or difficulties in making decisions. So those aspects of their brain function deteriorate first compared to the memory. Then you have Lewy body dementia. This is where they may look like as though they have got Parkinson's disease. So it's more of a movement motor disorder that initiates first. They may get what we call hallucination. That means they see things which are not there, or hear people talking when there's no one talking. So those presentation comes first before, as years go by, then they lose their memory. Yeah. So why we want to know which type is because it helps us also to give you a prognosis. That means the rate of deterioration and what to expect. The treatment is mostly similar in terms of how you support them without medicine. Okay? And frontal temporal is also very rare. It usually occurs in people of much younger age group. So that means they might be in their 40s when they started to develop problems with their brain function. Okay? Yeah, so this is more towards a behavioral problem. So people with frontal temporal dementia may have difficulties getting along with their colleagues. They may have social behavior issues. Those are, sometimes you might feel that, why this person acts a bit weird, you know, that kind of thing. So those are frontal temporal dementia. Now, so when someone suspects, oh, do I have, or does he or she, or does my loved one has memory problem or has dementia, this is what we as doctors normally do as we assess someone. Okay? Now, so when someone comes to me with suspected dementia, I would normally sit down and take a long time to go through the whole history of what has happened in the person's life. So if the patient comes on their own to look for us and suspect they might have memory problem, it's a bit harder for us to do a complete assessment because we need to clarify. Yeah. But if they can come to University Malaya on their own, you can imagine traveling to the hospital, finding the car park, finding the clinic, coming to the clinic on time. I also doubt they have memory problem. So you have to think about possibility of other causes. So a lot of times we want patient to come with someone that is close to them, who knows what is happening to them in their home. So there's so many sons and daughters who live overseas, then they come back, they feel that something's not right, they bring mother or father to the clinic, and when we try and ask what is the problem at home, sometimes they can't tell. So it's best to get someone who they live with, who knows them well, to be able to give us more story about what's been going on in their lives, for us to make a better assessment. Okay, so what do we ask? We want to know when did the symptoms started and how fast is the deterioration. Dementia is a chronic illness. It usually progresses very slowly and gradually. Many times family members will tell me, I also cannot remember when it started. Maybe last year, or maybe actually the year before already got a little bit. So those are what we normally hear. Rather than, no, last week they were fine. This week suddenly they're very confused. I ask them what they're doing, they don't know. That one is not dementia. That one you have to assess properly. It could be other reasons for the sudden change in their behavior or their memory. Okay? And other things is like, we ask about what kind of things they forget. Sometimes we also forget things, right? Where I put my key, I can lock the door or not, I can lock my car door or not. So sometimes that can happen to me also, or you, but doesn't mean that you got dementia, okay? So normally for dementia, the kind of things that they forget, they can't actually track back the course of where they misplaced certain belongings. And normally, sometimes they don't even remember that they've forgotten it. So that's more of a pathological forgetfulness rather than a normal day-to-day forgetfulness. And we also ask about the information that they forget. So we don't normally ask, they can remember what they eat yesterday. That is not a good question. I also cannot remember what I ate yesterday. So it has to be something more significant. So for example, something special that has happened, let's say 2 weeks ago, and you ask them, can they remember like so-and-so came and visit them, or when they attended a wedding ceremony? Those things they should remember. So you want to know whether they can remember fully about the event, or they totally cannot remember doing it, or they only remember partially. So if that was the case, something special happened, they totally have no recollection, that is not entirely normal. Okay? And other things is that day-to-day things, do they remember? So for example, I have got sometimes a lot of referrals from my colleagues, endocrinologists. They will tell me, you know, this patient that I have seen, you know, they've been taking insulin injection, they have been so good in doing it for years, now they cannot do it. Or I tell them to change the dosing, they still cannot do it. Or sometimes their chronic illness become difficult to control because they may have forgotten to take their medication. So those are sometimes also the main reasons or reasons of why they come to see us. And other times are crises. The family will come and tell me, they went out, they don't know how to come back. Those are crisis time. Those are when problems occurs in their self-care itself. I have got patients who they drive around and somehow there are roadblocks, there are road changes, they took a wrong turn, then they drive all the way to Ipoh, they don't know how to come back, family have to go and find them. So things like that can happen. So those are usually crisis moments. Okay? The other thing, just wanted to interestingly tell you about this sign. So many times also we observe the person as we talk to the patient, and they have this, what we call it, a term, head turning sign. So for example, you ask them a question, so how are you today? So who do you live with? Where's your house? You know, how are you managing at home? And many times the person with dementia have this habit, they look to their loved ones for answer. Hey, you know, that kind of thing. So that is a sign you're like, that's not quite normal. So other things, this is just to reassure you, there are sometimes forgetfulness can be normal type of aging. Our memory, our brain function is not static throughout our life course. So as we get older, our processing speed will slow down a little bit. It takes us a little bit longer to learn new skills, to sometimes recall new information, but it doesn't mean that you cannot recall. You should still be able to, but it takes a bit longer. And maybe learning new tasks will take a few more tries. Okay? So if you find that, oh, how come I have difficulties using this new handphone? Just that it take you a little bit more time, but you should not be totally unable to learn new things. Okay? Yeah. Now, the other things that, like I've mentioned, so sometimes persons living with dementia may have what we call perceptual problem. So they can't actually visually gauge either distance, places, faces. Then that can lead to day-to-day impairment. So if they go out, like I mentioned, they may not be able to find their way home in familiar surrounding. Not to say that they go to a new place, they can't find their way means they got dementia. No, I'm talking about familiar places that they should know. Okay. The other things we find also, it's about sometimes driving may be an issue. You might find that in terms of driving, the gauging of the distance between their car and the next person's car may not be so good. Say either drive very close to the other person, or they drive very close to the line that they're not supposed to cross. And sometimes I would normally ask family, what do you think about their driving skill? Then usually the wife said, he drive, I don't sit in the car. So then I ask, if you sit in the car, you feel safe or not? No. Then you know that they may have difficulties with the driving ability. Or you might want to ask, do they have any small little knocks and dents in their car? Because that will also tell you that their perception is not so good already. Okay? Then you may have to counsel whether the person should or should not stop driving. Okay. Other things are like, this is what we call problems with planning, problems with reasoning, difficulties in making decisions. So a person living with dementia may slowly develop these difficulties. So many times family will say they don't quite communicate as much as before. They are more quiet. I ask them whether they want to do this, they say, anything lah. They don't really want to make a decision. Sometimes it's also the difficulties in them processing it to be able to come up with an answer lah. The other things that they find also, that they stop doing things that they are good in doing. So for example, so let's say if we've got a person who's been a housewife, who cooks for the family for their entire life, and suddenly stop cooking. Sometimes stop cooking is also because the children say, get a maid, I don't need to cook now. That one not so good. Don't stop them from doing what they can do. Because once you stop, then they don't know how to do already. Okay? But at times it may be because they are finding it difficult to do already. So they eventually say, I don't want to cook anymore. You know, it might be a coping strategy that they're trying to exhibit. So it's because the planning skills have deteriorated. As you can imagine, I don't cook, but I can imagine cooking requires a lot of planning, right? You need to know how many people to cook for, what to put, when to put, so what ingredients to put. So it requires a lot of planning. So skills like that may deteriorate when a person suffers from dementia. Okay, so it's interesting also, we normally ask, are there certain things that they used to do and they cannot do now? That helps us to identify whether they have got problems with their executive function. Okay, yeah. And there are also other things like they can't learn or have difficulties in learning new skills. So for example, if you find that, oh now I changed a new television, so they have difficulties trying to switch it on, switch it off. I've taught them so many times already, they still don't know. They're so lazy. Actually, it's not that they're lazy. So sometimes family members might misinterpret these changes that the person living with dementia has as don't want to do, lazy, not motivated. But it's actually the disease that causes that to happen. Things we find also, it's problem with their communication. So communication problem can occur in the sense that they have difficulties understanding what is being told to them. So for example, they might start to become more quiet. So they got family reunion. Usually they are very talkative, they can communicate very well. But when a person suffers from dementia, they may have difficulties understanding where this conversation is going. Because you sit together, reunion, this person talk to that person say something, this person talk to this person. So the person living with dementia might get confused, where are things going? So what do? they remain very quiet, they talk less. Other times it may be that they have difficulties expressing themselves. So they might have difficulties telling you what that thing is called. You know, the thing where you sit on it, or you know, that thing where you change the channel. So they have word finding difficulties. So they may develop difficulties in expressing themselves. As you can imagine, it can be very frustrating, you know. So and this frustration sometimes can lead to behavioral problem, which we will talk about later. Okay. And other times also you want to see how they are able to behave in a social environment. Okay. In the early stages of dementia, a person living with dementia may be able to communicate like usual, but if you have a more in-depth conversation with them, you find that, why do they keep repeating the same thing over and over again? How come the story is the same? They just told me that, now they're telling me again as though it's the first time that they're telling me that. Or how come the person asks me the question over and over and over again? Like, when is my son coming out? When is my son coming out? Yeah, so you can imagine the first 2 times you answer is okay lah. After the 10th and 11th time, you're like, I told you that already. That frustration can come. So we can all identify with that sometimes. Okay, so these are what we call the behavioral and psychological symptoms of dementia. These symptoms can be a manifestation of dementia. And many times, if you look at a person in the course of their life suffering from dementia, 90% of people living with dementia will exhibit some of these symptoms throughout their journey in different intensity and degree. So they are people who are very mild. You know, they stay at home, live with their family. The family asks them to eat, they eat. Asks them to go, they go. Asks them to shower, they will do. But it's just that they're forgetful. But no problem. These patients sometimes don't come to us because can handle. The ones who come to us are when they exhibit these symptoms. They cannot sleep. They walk around inside the house. They always wanted to go out. You don't let them out, they will shout, they will scream, they will throw things at you. Or sometimes they might keep accusing people of doing things that they haven't done. You take my things, you steal my things. Where's my wallet? Where's my money? You take my money. You know, these kind of things. Or sometimes even in husband and wife also, things like this can happen. Why are you going out again? You're looking for that woman, is it? So stuff like that can happen, and we hear a lot, and it's not uncommon. So these behavioral and psychological symptoms of dementia are usually reasons why patients land up in our clinic, because it's getting more and more out of control. And sometimes people don't recognize that this is also a part and parcel of the disease itself. They might feel that they've got psychosis, they got depression. Okay, so manifestation could be in a wide array of symptoms. And why do some people have these symptoms? Although I tell you that it's part and parcel of the disease, but it doesn't mean that we just look at the disease. Sometimes, most of the time, it's a manifestation of what we call unmet needs. There are certain needs that they cannot communicate, so it exhibit as a symptom. You know, you can imagine if me and you, we want to go out, we go out, right? We want to eat this, we eat this, we want to do that, we do that. But the person living with dementia, they may still want to do that, or they will want to do that, but it's just that they cannot realize that certain things that I do, it can be dangerous, and therefore my family don't let me do it. And therefore my family thinks that it's better I stay at home. But can you imagine when we were quarantined because of the MCO, we also get a big net already after 2 weeks in the house, right? Moreover, the person living with dementia, if they are being asked to stay in the house all the time. Okay, that's why I say that sometimes the manifestation of the behavior is because that there is a need that they have which is not met. And a lot of times, understanding what that need is and satisfying that need in creative ways can reduce the need of medicine. Because many times people come to me, cannot sleep, can take medicine or not? Very, talking the whole night, can take medicine or not? Wandering up and down, can take medicine. A lot of this no medicine to take one. Okay, so at times they may just be bored, they just need some meaningful activities to be done. So they might say, I want to go out. And when you bring them out, they say, no, I want to go home. Yeah, so at times it might just be bringing them for a short walk, coming back is enough to reduce that agitation. So we just have to find meaningful ways to cope with some of these symptoms. Okay, now, so after understanding the person as a whole, like I say, I want to know how they're coping at home, what do they do at home, and how are the family managing them, and also how in terms of their other medical status as well. So sometimes relatives say, I bring him to see you because of dementia, the other diabetes, high blood pressure, got doctor look after one. So I say, I know, but then again, if I don't know how well controlled these medical illnesses are, it will impact on the brain. I cannot just treat the brain. Yeah, so we have to think of it as a holistic view of the patient in terms of the management. Okay, so other things like I say, I want to know what they can do at home, beyond self-care. Can shower, can eat, can go toilet, can transfer or not, but I want to know, can they go out on their own? Can they use money? Can they count? Can they keep themselves safe? If they do use gadget, they go to the kitchen, they use the kettle, electric kettle, will they put it on the stove? If they go out, will they leave the door open? Things like that I would like to know. And I also learn a lot when I speak to family members about how they cope with certain symptoms. So there are a lot of interesting things that people do. So for example, this lady likes to go out. You cannot keep them in the house all the time. So the patient can still go out, can come back. But of course, you want to maintain safety. Do you know what she's wearing here? The family put it on to keep her safe. It's an air tag. So you can track where they are and find them in case you can't find them. And then another lady who came also, I found it very interesting. I was like, how come her baju got embroidered numbers on the baju one? So it's embroidered telephone numbers on the baju. Because she might go out, family scared, she don't know how to come back. So I asked the daughter, what if she changed baju? Oh, she only got 12 blouses. We embroidered on all the 12 blouses. I was like, oh, okay. That one is your number. No, my brother's number. Oh, you're very smart. Very clever. Yeah, so that many times if they see her wandering around, either a security guard, the neighbors know the number to call to bring the person back. Yeah, so these are many different gadgets out there. Some people are tracking watch, but you must make sure they wear. You got a tracking watch, they don't wear the watch, also don't use. Some who drives, they actually install the tracking device on their phones. So that has helped some certain family as well. If they can't find them, if they're driven out and they don't know how to come back. Yeah, so lots of different things to help family members cope with caring. Okay. Other things are like I say, we want to know their medical history, their drug history, because that helps us in our assessment and diagnosis. Okay, and what kind of support they have, because they are older people who live on their own, memory not so good, but not too bad. Have difficulties coping, family members are supporting in a way. Sometimes they will make sure that food is being delivered and stuff, because everybody needs to go to work. Yeah, so at times family members just cannot support 24 hours. Yeah, so some will install CCTV, different things. So we also want to know what is the support system, and also give advice to family members, because as disease progress, their needs will change. It's better we prepare early, then we start preparing when there is crisis. Yeah. Okay. So we do tests also. We do an array of tests. We do blood tests. We do imaging, that we do a CT or an MRI scan of the brain, and depends on the presentation of the patient. Sometimes we might do other tests also. Is it a must to do a brain scan? Of course, nothing is 100% a must lah. It will be very, very good to do. It will help us with the diagnosis. Can do, I will ask them to do. Let's say if I've got a 92-year-old lady who is going to be so agitated, if I put her through a scan, then I don't do lor. So it's case by case basis lah. All right? And yeah, so imaging test lah. So what do we see in the brain scan? Does it mean that if I don't do brain scan, I don't know what the diagnosis is? Not really. Yeah. So the brain scan helps us to support our diagnosis, and sometimes it also helps us to identify which subtype of dementia are we looking at. Okay. And also I do brain scan because sometimes it might surprise you also lah. I've got a lady who memory is not so good, may have difficulties remembering what was being told to her on the telephone. And eventually when we did a brain scan, she's actually got a growth lah. Yeah, so things like that helps us to rule out other possible causes or other non-dementia causes lah. Okay, so this is just a rough guide lah about how the dementia disease will progress. Unfortunately, up to now, when someone is being diagnosed with dementia, as you can see, the line goes down, the line doesn't go up. So a friend of mine gave this analogy about dementia. So dementia disease is a progressive illness. So it's like, for example, you are taking a train from Singapore to Hat Yai. This train is non-stop one. It will continue to go up. It won't go down. Sometimes knowing how to manage the disease, giving appropriate treatment, just slow the speed of the train. It doesn't stop the train. It will not stop in Penang and never go up. No lah. As you can see, the line will go down. But the question is the speed lah, of how fast it will go. And because at a point when your brain function deteriorates to a level, the person will need help with care. And that is that point that you don't want to reach so fast. So you want to slowly allow the disease with support not to reach that stage so fast. And other things that I would also like to explain to family members that it's not just about the brain. Yes, dementia will slowly progress, but the health of the person is also very important. If the disease was going to slowly progress, but let's say you have an infection that requires hospitalization, you had a heart attack, you had a fall, you fractured your hip, then you will find when the medical health drops, the brain function also drops. So instead of going like that, it would have gone like that already faster. So rather than thinking, oh, what medicine to protect the brain, I would say make sure that general health is good. Okay, if your diabetes is not well controlled, and your high blood pressure is very high, and the patient keep falling as they walk, whatever medicine I give you for the brain is not going to help very much. So you control those ones as well. Okay? Because once they have an acute illness, when they drop, yes, acute illness get better, they might improve a bit, but a lot of times they may not go back to their baseline. So they go like that until another problem comes like that. Oh? That's why we want to reduce that from happening. Okay, now treatment for dementia. So some people say, got medicine to take or not? There is medicine that we prescribe. And what do the medicine do? Like I say, the medicine also don't stop the train. The medicine might slow the presentation of the symptom. A bit like how you improve your brain reserve. You have got two persons with the same disease burden, the amount of changes in the brain, but one person is active doing things, so they might not present with the first symptom of dementia there and then. It might delay like 3-4 years before they present with forgetfulness. You have another person who don't do anything, Don't read and stay at home a lot, don't go out. Today, what day, what year, what month also doesn't bother me because every day is the same, and no activities at home. And with the same disease burden, they will present with the symptom now. So, hence, when we talk about delaying the onset of the symptoms, it's important. So the medicine can help that. The non-medicine, for example, engagement, family understanding about the disease, know how to talk to them, also can help that. Okay? So this is what we want to ensure. They have to have a lot of love. Okay? People come and tell me, oh, you're a geriatrician, you must be very patient. I said, I'm not patient. I only see the patient 1 hour. You see the patient 24 hours. You are more patient. Huh? So there is a lot of patience, a lot of love, a lot of comfort, and you need to try and include the person also. Just because the brain function is not the same as what it was before, doesn't mean that there is no function. The person is still the person that they are, but they just have some gaps in understanding what is happening. So our job is to try and fill in these gaps to make it easier for the person. Okay, so maintain their comfort, give them the emotional support that they need, making sure that the home environment is calm. If we are hostile, it will make the patient more hostile. If we are calm, we are tidak apa, they also tidak apa. If there's a lot of scolding, shouting, screaming, then it will also not be so good for the person.
Okay, I must have pressed something again. This time it might be out of battery.
Sorry. Okay. Yeah. So the other things is engage them with activities. Because I keep saying activities. You'll be thinking what sort of activities. From young also they got no hobby only. They work, finish working, nothing to do. Okay. But sometimes there are some things to do. Either engage them in new hobbies or things that they like to do before, but maybe don't give it in a such
difficult level. So you want to ensure.
The mic having dementia. That's one, two. Okay.
Okay, yeah. So these are some of the examples. So basically, when I say activities, I always suggest that they do something that require them to make a response. So, watch television. Is it a good activity? You sit there. No, because watching television, sometimes you don't know, you watching the television watching you, right? Yeah, so there is no response required. So not a good activity. Reading book or reading newspaper, they always read newspaper. But actually we don't know, and they might be reading the same sentence over and over and over again. Sometimes when I study also, I read the same sentence over and over again. That one also not a good activity. But instead, if you read, you can, but you read out loud. So you read because that requires you to make a response. And that is fine. You watch television, can you watch with someone and talk about it? Maybe can. Okay. So activities that require them to do things with their hand can, but not always coloring. I know every time we talk about activities for a person living with dementia, you buy the one whole set of coloring book. I do coloring. Coloring can be very boring. If I got dementia, don't give me coloring, okay? Give me something else. Yeah. So you can think some people like word search, some people like calligraphy. Other things that they are still able to do, for example, singing is good. Because people who sing a lot, less likely to get dementia. People who dance a lot, also less likely to get dementia. Why? Because when you sing, you have to follow the rhythm. And you have to follow the lyrics. So it makes your brain think. When you dance, also the same thing. You need to know which leg to turn, which hand to go, where to turn, and this and that. That one also requires a lot of thinking. So people who play music also very good. So those are things that you can consider. Okay? Not watch television, watch Korean drama, not so good. Okay. Right. Now, that's one thing you heard of people say, oh, you play mahjong, you won't get dementia. It's not actually the mahjong that is so supernatural. But it's because when you're playing a game, mahjongs are only 4 people, or is it 3? Okay. 4. Okay. So basically, when you play with people, you have to talk to the person. You cannot be playing mahjong without talking. So there's a social interaction. Okay? And when you're playing mahjong, you need to know what stack to put, when to put, who put what, when I put, when it's my turn, and how to win. So there's a lot of critical thinking skills. Okay? But don't play with money. Okay? So not just mahjong. So for example, if you play any games like snake and ladder, chess, Chinese chess, that requires someone to play with you and you making an action towards what you think you should do, and that is critical thinking. So you should vegetable, cut a bit this and prepare that. Sometimes you find that so long it takes. Yes, it might take longer, but in the long term, it's better for the person. Okay? So include them in activities. Don't always make all the decision, but don't also always ask them, which one, what you want to eat today now? Tell me, cannot. Sometimes, what do you want to eat? If my friend asks me to go out and eat, I also don't know what to eat. So you give them a choice. You want A or you want B? Easier to make, okay? And so other things that you want to also prepare family members. So you talk about safety, ensure that the environment is safe for them. You might also want to think about future planning. So even things like who's going to make decision for them if they cannot make decision on their own one day as the disease progress, whether is it financial decision or even decision on their own health itself. Okay, so things like that, it's usually better to talk earlier than only think about it during crisis time. Okay? So everyone wants to feel belong and attached. So sometimes you might find that the person living with dementia may have a lot of anxiety when the person closest to them are not around. So I have spouses who tell me, I go out for a short while only, you call me 3, 4, 5 times, asking me when is Nan coming back, when is Nan coming back? Yeah, that's because to them, you are a person that they feel safe with. They know that if they cannot answer certain things or they cannot make sense of what's happening, you are able to help them. So that's why they are more attached. Okay, so these are some of the non-drug treatment that I have earlier mentioned. This is just a picture to it. Okay, so activities, making sure that they are physically active and making sure that they are also included in social interaction. Okay, you'll be amazed, Some family will tell me, wow, sometimes so good at the memory, can remember everything like no dementia like that. Then other times cannot remember. You think they're purposely doing it or not? No. Like your internet or say the mic connection, sometimes very good, sometimes not so good, right? You also don't know why, right? So sometimes it's to do with the connectivity that is happening also. Okay? Okay, so some of their other support. So if you know someone who may have dementia, you have your loved ones who have dementia, you can go and join the Alzheimer's Disease Foundation Malaysia website. They give you a lot of information. They also give you information about talks that healthcare professional does. So this is just one short 1 hour talk, so trying to cram things in. But they are also caregiver training workshop. So it runs about 1.5 days and it will give you lots more information. And you come together with people who may also have the same problem as you. And it's very interesting because you can see how other people cope with those problems. And you will be amazed what tips you will get. Okay? Oh, yeah, so there's also another dementia care center. This is actually a collaboration between the Genting Group and also University of Malaya Geriatric Unit. So one of our colleagues helps to manage the center. So it's a purpose-built building to provide activities for people living with dementia. But because there's so much need, so now got waiting list. But it's okay, you can put your name on the waiting list, okay? They'll call you when you can. This is a gambut. Okay. Oh yeah, so then for people who have mild dementia, or maybe not even dementia, some people call it pre-dementia. Basically, they may feel that, I'm a bit forgetful, I'm not the same like before. And then when you check objectively, memang their scores are not so good, but they're still functioning very well. So there are other activities that they can do. So this is called the University of Third Age under UPN. So they have lots and lots of courses for older person, not just for those with dementia, any older person. Remember the life course?
Dr. Khor say don't stay at home and shake leg only, right? They can consider taking up some of these courses. There are people do photography, they do painting, they do singing, they do accounting, so programming. There are lots of different courses, short courses that you can do. They tell me it's best you Facebook them to find information. Okay. And so medicine. Medicine, I'm not going to go into every specific medicine. I'm just going to tell you the difference between taking medicine and not taking medicine. This line, not taking medicine, it will go down. What medicine does at the initial early stages, bring you up a little bit, as in bring your symptom a bit better. However, as time goes by, the line also goes down. Okay. So for example, a lot of people come back and tell me, take the medicine, no change. Exactly the same. Okay? There is a possibility that that happens. So we do assessment. A common assessment we do is the mini mental test score. So we ask questions, then we jot down how much they score. So the total score is 30. So sometimes the patient might score 15. Or you might think, pass. Actually not pass. 15. And if they take medicine, and I repeat the test again, how much do I expect it to improve? 15, I always tell them, it's never going to go to 25. 15, you take 3 months, 6 months, it might go, if you're lucky, 16, 17, or might be 15. If 6 months later is 15, it's still good. 6 months later, still 15, also good. Because you don't want 15, 14, 13 like that drop. So that's what we are looking at in terms of the medicine. But of course, this is just a score. Some family members can see some difference. Oh yeah, now they're a little bit more engaged, when we involve them in activities. Oh, now last time they had difficulties finding the toilet, now they can. So those things I cannot find in the score. Doesn't mean there's no improvement. Okay? Yeah. So this is our main aim. My last slide already. What we really want to do, at the moment we could not reverse the disease. But what we want to do is enhance whatever cognition that they have for as long as we can. We want to maximize their function and maintain what they can do for as long as we can. We want to, in doing that, we hope that it will improve or maintain the quality of life. And if there are difficulties in their behavior, we want to help manage the behavior. Because if the behavior is so difficult for family members to deal with, most of the time we give up. I cannot look after them anymore. Or if we cannot look after them anymore, then someone has to look after them, right? Or a center has to look after them, right? So we want to ensure that we give you the amount of support that you need so that they can remain in their own environment for as long as possible. Okay? I think that should be the end of my talk. Thank you very much for your attention. Okay.
Thank you, Dr. Khor, for such an insightful sharing on dementia. Perhaps, because it's not quite 2 o'clock yet. Doctor, are you okay to take maybe
Yes,
one
yes.
or two questions?
Sure.
Any questions from the floor? Oh, wow, a lot. I tell you, Dr. Khor, normally, I'll pass my mic, but normally downstairs we have the Dharma talks, right? The Buddhist class talk. Any questions? Nobody raised up the hand.
Maybe too many people.
Yeah.
Thanks, Dr. Khor. I would like to ask, how do we prevent dementia?
Very good question. Which is why in my first few slides, I showed that to you about the life course. Very simple. So basically, if you think about healthy living, that's one way. So number one, if you have chronic illness, you must ensure that your chronic illness is managed well. So everything is well controlled. That definitely helps, because we find people who have a lot of what we call vascular burden. So for example, diabetes uncontrolled, hypertension uncontrolled, it's also not so good for your brain, because these problems do not just clog up your heart vessel, they can also clog up your brain vessel. They don't just choose the heart only, they can go to the brain also. So that's why we want to control them. And at the same time, in terms of diet, eating well, healthy. You might tell me, so what sort of diet? The Okinawa diet, Mediterranean diet, Malaysian diet, Singaporean diet, colorful. So usually we will say,
If you, for example, either is it Okinawa or Mediterranean, you look at the 5 portion of what you need to eat, 5 portion of fruits and vegetables, protein, not so much carbo, sugar definitely cut down. So those things can also maintain your physical health. Exercise is very important. It's very important, honestly, because it prevents not only brain problem, every single problem with exercise will improve. And exercise is not something, I do 3 months exercise, will last me for 3 years. No. You do 3 months exercise, last you for 3 months only. Okay? Then as you continue to do the exercise, you will continue to reap the benefit. As we all get older, we lose muscle mass. And that is very important. You want to maintain your muscle mass. You might say, okay lah. Like Sonia might say, women don't look the same already lah. But let's say I'm still wearing the same trousers I wore 20 years ago. Yeah, the size, diameter might be the same. Content may not be the same. Last time got more muscle, less fat. Now got more fat, less muscle. So that's why you need to build up your muscle mass. Now we find that a lot of things are associated with muscle mass. How well you survive COVID, how well you survive a pneumonia, how well you survive a surgery. All depends also on how fit you are. Even people who go for knee operation, hip operation, nowadays, because I do a lot of fracture management and stuff, we ask them, even on they tell knee pain now cannot exercise. They are still exercise, you can do why? Because even if you're going to go for your knee replacement, you need to make sure your muscle is strong, so that your recovery from the surgery is better. So exercise is very important. You might say, I do so much housework, I mop the floor, I clean the house, that is not exercise, okay? Physical activity and exercise is different. They will tell you. Exercise is exercise, the time you take out to do the exercise. And exercise is not static. I walk at the park 2 rounds every day. And so easy, I can walk and sing a song, talk to my friend. And that one is very low intensity. As you get better in an exercise regime, you need to increase the intensity. There need to be that challenge. I'm not saying you should do the walking, Dr. Khor say do more, I do more, until you cannot talk. No need. Moderate intensity to go for 65 years and above. Okay? Moderate intensity is what? You can still do it, but it's not so easy for you to talk already. You can still talk. Okay? But there must be an increase in your heart rate. Okay? High intensity is different, like playing badminton already, competitively. Okay, yeah, so exercise is important. And like I say, the brain, so continue to do what you are doing. Sometimes it will be good to challenge yourself to learn new things. I have always used, let's say I've always used a laptop which is non-MacBook because I don't want to learn. You change to a MacBook, you have to learn the new things all over again. So you try not to be like that. I am Android user, I don't want to use iPhone. You can try one. I'm not iPhone user. Because the reluctance to learn new things is not good. So you must always challenge yourself to learn something new. Don't say, nowadays the young people do like that, I don't do one. No, you must follow the trend. So those are the things. Because once you stop at the level, you always stop there. And then your brain will just go down. Because if it's not going up, it will go down. Okay? So that's why always mental health, physical health, chronic health, and diet and what you eat. Very important. Very simple only. Don't ask me what supplement to take, what medicine to take. Yeah, the evidence is not so strong. Okay?
Okay, thank you, Dr. Khor. We have one more question here.
Dr. Khor, just a quick question from a caregiver's point of view. My mum was a very high-functioning individual in terms of juggling a career, children, etc. And this was a time, we're talking about the 70s and 80s, where it's really tough to bring up a family. What we've noticed is now, my siblings and I, she has always been an alpha personality, and this aspect has been amplified threefold, fourfold. Yet she can differentiate between the alphaness on certain people like me and my wife, the caregivers, and my siblings. There's a degree of latitude given to my siblings which is not invested in me. So it's really, really frustrating. Just wanted to share that with you and get your opinion. Thank you.
Yeah, thank you for that sharing.
It can be, it is really very difficult. And sometimes I think we don't give enough support to caregivers, unfortunately. Yeah? So definitely joining the Alzheimer's Disease Foundation helps because they do have caregiver support group. I think it runs, can't remember, it's every week or every month, but in their website has it. And in terms of sharing with people about what other people do, also give us some hints. But like you mentioned, because someone, when they do have dementia, it doesn't mean that they lose everything. Most of the time, they maintain who they are, and they think that they can do what they do. So what I say is still correct. They cannot understand why you keep saying that they're not right. So sometimes there are difficulties in that understanding, that there is a lot of clash, and that actually exhibit a lot of unpleasantness, agitation, anger, frustration that happens in a household. Definitely, what I always say, if possible, certain things that a person does, they may not be able to follow totally the routine that we have set. You know, I think you should wake up now. You wake up and you still don't brush your teeth. Actually, don't brush teeth now, also never mind one now, okay? So if you have a little bit more flexible mentality to it, will help your sanity and their sanity. Some caregivers might tell me, "Wow, this 1 week only shower the head 1 time." Okay lah, it's okay lah. You know, as long as it doesn't, it's not detrimental to the actual physical health, we can be a bit more flexible. So you need to understand that it's very hard for them to fit into your routine. We need to try and adapt to their routine as safe as possible. Of course, there will be certain things that the person living with dementia wants to do it is not safe. Really cannot, it is not safe. Then it is when creativity has to come in. The question is, how do I try and mitigate this problem? How do I reduce that anger, reduce that frustration, at the same time care for the person? Engagement them in certain things, taking them away from the environment or the situation that is the trigger will help. Distraction will help. If they demand certain things that they think this is true, then maybe you say yes. But no need to say, hey, yeah, you know, yeah, no, no need. Just say yes, understand, and distract to something else. And those are some of the ways that can be done. But I also understand, if you are the main caregiver and you are trying to do your best, and sometimes not getting the kind of support that you wish you would have, but instead get a lot of unwanted opinions that can make things even more frustrating. Yeah, so definitely caregiver also need to have rest. You need to understand, because lots of caregivers who come to me, they need to see the doctor more than the patient. And I will tell them, you need a break. But to them, cannot, nobody can help. No one wants to help, cannot, and they don't want to go to who and whose house also. But we try to find a way. Of course, they may not move, but maybe 1 hour, maybe in some ways they can help you. Receive whatever help that you get. Take it only. Don't feel bad. Because our Chinese, right? No. So you need to get as many support as you can. Because this is a journey. This is not, sometimes not a short journey. This is a journey that you have to walk through. At times, even years. Yeah. So yeah, I hope that helps a bit.
Two questions, Dr. Khor.
Okay, I'll answer that question in a while. Yeah, sorry.
Okay, question number one. Quite a common symptoms that dementia patients always fear or blame others for truly their money, clothing, underwear, etc., etc. Why is that so? The sense of insecure is so strong.
Yes. Sometimes I find the money is very common now. So sometimes someone's given them money, like, oh, my son gave me money, and then they will hide it, they will keep it, then they cannot remember where they hide it and keep it. To them it's like, my money is missing, ma. It cannot be me that I forgot where I put it. It must be you that took my money. It must be the maid who took my money because they cleaned the room. So they do that at times is to try and fill in the gaps that they may have. Because they also want to make sense of why things like that happen. So that is sometimes an easy, the brain makes them think it that way, to cope with how things are happening in their lives. So we find that quite often. So if you got a lot of money, you want to give the money again. You've got Otherwise, sometimes, there are different things people would suggest. Like say, for example, make two of the same. So if a wallet, they buy two of the same wallet. So if they cannot find one, you can, hey, I found it already. Something like that. Or, but then again, a lot of times people say, I show them the video, the CCTV. See, it is them, it's not him, it's not her. I show them the evidence. No point of the evidence. You only create more frustration, because even you show evidence also they will say no, it's not the case. So it's not the case. So if you could not diffuse it, divert it, do other things that they are happier, get other people to see them that they love to meet, to try and take that away. But not argue. Especially if you're very angry, don't argue.
We give them fake money.
No comment.
Secondly, in Malaysia, what is the racial breakdown of dementia patients?
I have to say that we don't exactly have a Malaysia data of the breakdown. Of course, if you ask me, because it depends on the population around the area that I serve. University Malaya, 60% of patients will come in Chinese. Then you have 20% Malay, 20% Indian. So a lot of my patients are Chinese. But actually, if you look at the whole of Malaysia, I would say the percentage is also likely to be the same ethnicity breakdown that we have. I don't think it will particularly just affect particularly ethnicity, definitely much more than the other. But we don't have the exact data to it.
Okay, thank you, Doctor.
Sorry,
there's one more.
last question. Does Parkinson's disease lead to dementia? The short answer is it can. So Parkinson's disease is also a neurodegenerative disease. So basically, it's also a disease a person has that can continue and slowly progress. So many times we see people who has Parkinson's disease, after years and years and years, they can develop dementia.
Okay, thank you so much for all your questions, and of course, thank you, Doctor, for answering all our questions. Can we give Dr. Khor another round of applause, please? Doctor, to thank you for your talk today, we actually have a small token of appreciation to provide to you. Could we have Brother Danny, the President of Bandar Utama Buddhist Society, to present Dr. Khor with a small token of our gratitude?
Thank you very much.
We just have a photo. And remember, ladies and gents, if you would like to know more about dementia, Alzheimer's, feel free to visit the Alzheimer's Foundation of Malaysia. There you can find a bit more information. They have a physical, booth at Asia Shopping Gallery, not too far from here, as well as remember to search them on social media if you would like to know more. And once again, thank you so much to Dr. Khor. Give her a round of applause, and thank you so much, ladies and gents, for joining us for this Alzheimer talk. Our booths are still open. Some of it, the F90 booth is still open. So as Dr. Khor mentioned just now, leading a physically active lifestyle, exercise, and a good diet is things that can prevent dementia from occurring. So if you would like to know more, please head on over to their booth. And I think some of the other booths may be closed at the moment, but not to worry. And just another reminder that we also have the Wesak blessing session ongoing up to 2:30 p.m. downstairs. And at 3 p.m. we will have a Dharma sharing session by Bante Wat Po, also downstairs in the Buddha Shettiya Hall. So we'll see you soon.
Dementia. So basically, as long as they have an impairment, at least one function of the brain can come assessed first.
Then dementia or not, then we will.
I've got one short question. Somebody mentioned it to me that Chinese has more this machine program because in Chinese food, they always say less oil, less oil, less oil. Then become oil. No oil. Is it so?
Not that I know of at the moment, but I know there are a lot of people who take different things to reduce the risk of dementia. In fact, they suggest people take virgin coconut oil for to reduce the risk. But if you say that, is it very, very effective? I have to say, it's people who take and people who don't take, not a major difference. I do have people who come back, hey, very good okay good can take because no harm yeah. But if you say that you just take, but I don't want to take medicine when the person actually need it, then cannot
No, this is more on the prevention side.
Prevention side we don't know actually, to be honest. Yeah. Usually those ones are already have memory symptoms.
But there's no reverse
Correct. But like I say rather than taking the oil, exercise condition all those oil based as in food olive oil. The olive that you take can, those kind of things tomatoes because of antioxidant, those kind of healthy food is much better
Okay, one more question. You talk about the dementia care center. Is there only one in the whole of Kuala Lumpur?
No. So
there must be some
NGO based. So like NGO based, non-private based is these two. So either the Alzheimer's Disease Foundation Malaysia, it's opposite UN, section Jalan University opposite there. That one has been there for a long time. So that is, but they do charge a small fee. So every day is like 30 ringgit or something like that. And then the other one is the Genting Dementia Center, Dementia Care Center. So that one is in Sedangput. There are also other ones who call themselves also day care center for people living with dementia, but those are all private based.
At least there are some other helps. Okay, that's good. Could stress cause dementia?
A lot, So basically, depression, mental health problem, very closely related to your cognitive health in the future. So we see also people, let's say besides depression, people who's got schizophrenia or mental health problem, even in their years, as times go by, the risk of developing dementia is also higher than normal population. Definitely stress, because stress can lead to mental health problem, which then again increases the risk. So definitely it has some linkage in some ways.
Because stress causes you can't sleep at night, so resulted not enough rest to your brain. So it may be one of the main causes.
Let's say, very hard to say because when a person cannot sleep, are they already starting to develop insomnia or sleep disorder? So if that was the case, is this problem related to an underlying mental health? So those are actually the symptoms. The question is what is causing that symptom? The illness itself, is there going to be a direct relationship with dementia? So basically, we also find that, like you mentioned, stress management, social interaction, healthy lifestyle is all very important. Part and parcel of the disease.
There are a lot of old folks who suffer from depression. That can also cause
increase the risk.
And if they're on depression medication, will it help in that sense?
Definitely, we find that it being treated is important because a lot of people might think that they got dementia, but actually they have depression. So you must treat the depression before you can say this person got dementia or not. So it's important to receive treatment for it.
So it's still okay to go on depression tablets, but some people say don't do that.
No. If they are memang has depression and they require treatment, then they should.
So what kind of doctor should we first of all make the patient go?
Can try. I would say that if possible, we always suggest the patient to go to their normal general practitioner, the usual general practitioner, to get it assessed first. Of course, if the general practitioner feels that this is something that requires a specialist care, then they will refer on. So basically, mental health problem normally will see the psychiatrist. But of course lah, if they're 85 years usually we will say come and see us lah.
Even if you don't see psychiatrist, like my mother was given the impression by the
GP lah.
GP because she has to manage her depression. And after she called it happy pills. To make her more relaxed and happier because if not she'll be all down.
Good. If she's happy already, okay. The GP can treat one, can. But if like they start treatment and they don't see an improvement, things get worse, then of course this one needs to escalate to specialist.
Because it affects her meals, she eats a lot, she cannot sleep a lot. So with the happy pills she's so much better.
Because sleep is a very complex thing. Some people will pray, just make sure that they don't so anxious before they sleep.
So use essential oil, what's your opinion?
So can also. Essential oil, aromatherapy, whichever that can help, can. Yeah. There are people who will start taking even melatonin. Melatonin here, Malaysia don't sell. Outside in other countries, melatonin is like a hormone that our body produces during nighttime one. So a melatonin is an internal hormone that our body produces during nighttime. It increases, so then it helps us go to sleep. So in like Singapore or other places, the melatonin is like a supplement. So people say, the melatonin level higher, then they can sleep better. But so basically, it's to maintain hygiene, reduce the stress, and if can, daytime do a bit of exercise. Don't do evening walk, do a bit more during the daytime. Relax yourself, then sleep.
In a way, coming back from work, exercise during evening time is not a good idea, generally.
If you can choose, just because when you exercise, you release endorphin hormone, which makes you excited and happy. So too much excitement and happy.
Before sleep?
Before sleep, not so good. You do it in the morning better.
Things like coffee, tea, some
you reduce it. During the evening.
Sorry, 那個唔瞓得嘅 definition 係 like whole night 唔瞓得 or like in between wake up then take a while. I mean wake up for toilet, then want to sleep back, then take a while to sleep back. That
嗰啲嘅仲瞓得，
嗰個係仲瞓得，唔瞓得係到底唔瞓得。
唔瞓得係有啲 is 好艱難入睡啊！喺嗰度好艱難入睡。some people 係太即係瞓覺咗，but then 好緊要早就起身瞓唔着咗啊！嚟3點幾就起身啦，唔瞓得着咗啦。呢個係瞓覺問題，and 呢個問題 persistently 啦 for 2 weeks or more。即係有時我哋都會唔瞓得1-2日嗰啲人唔緊要，it's really persistently 好耐 2 weeks or more 就要 check 下佢。Okay, thank you. Okay, no problem. Thank you.